All right, everybody, it's about a minute past the top of the hour, so let's go ahead and get started. Welcome, everybody, to our September Neurocritical Care Society Pharmacy Section Journal Club. We have two presenters today. The first presenter will be Madison Fielding. She's a PGY2 critical care pharmacy resident at Yale New Haven Hospital. And our second presenter today will be Michaela Rhodes, who is a PGY2 critical care pharmacy resident at U of L Health at U of L Hospital. So with that, Madison, I think you can share your screen and take it away.
Okay, great. Thank you. Give me just 1 second to get my slides pulled up.
All right, everything looks good. So you're good to start whenever you're ready.
Okay, great. Thank you. So today I'll be talking about an article titled Perampanel as an add-on therapy in patients with refractory status epilepticus and post-anoxic encephalopathy. And this is a real-life single-center retrospective cohort study. Oops. So kind of just to give us some background information, I'm sure a lot of us are kind of aware of what these definitions are, but status epilepticus in general is a clinical or encephalographic seizure activity lasting greater than 5 minutes, or recurrent seizure activity without fully returning to neurologic baseline between your seizures. And so there is a proposed algorithm for the management of status epilepticus. And so the first 5 to 20 minutes are called the initial phase. And normally you would initiate therapy with a benzodiazepine at this point. So normally you're going to be using either intramuscular midazolam, intravenous lorazepam, or intravenous diazepam. And if none of these three options are available, normally we would choose either IV phenobarbital, rectal diazepam, or intranasal midazolam. And then the next kind of phase would be around 20 to 40 minutes, which is also called the urgent phase. And in this phase, you would normally choose between fosphenytoin, valproic acid, or levetiracetam. And there's really not any evidence-based preferred second therapy for based on the guidelines, and they just recommend either using IV fosphenytoin, IV valproic acid, or IV the levetiracetam. And if none of those are available, would just choose IV phenobarbital if not given already. And so this is kind of what we'll be focusing on today for this presentation. So about 40 plus minutes after the initial seizure activity, this is called the refractory phase, and there isn't really any clear guidance in terms of therapy or management. So our choices really include repeating any second-line therapy or anesthetic doses of either thiopentol, midazolam, pentobarbital, or propofol. And all of these would require continuous EEG monitoring as well. And then here's just a breakdown of kind of how we classify status epilepticus. So we have convulsive and non-convulsive status epilepticus. And from there, we can go into refractory status epilepticus, which is non-responsive to our initial agents, and then to super refractory status epilepticus. So for post-anoxic encephalopathy, or PAE, this is a devastating consequence of an abrupt cessation of cerebral blood flow, most frequently observed after resuscitation in the context of a cardiac arrest. And on the EEG, we see patterns in myoclonus frequently observed. However, treatment strategies are still a matter of debate, especially how aggressively this should be treated and which drugs might be the most appropriate for management. So this brings us to perampanel or Fycompa. So this is a third generation anti-seizure medication, which acts as an AMPA receptor antagonist. It works to reduce glutamate-mediated postsynaptic excitation, and it's currently approved to treat focal onset seizures, including focal to bilateral tonic-clonic seizures and primary generalized tonic-clonic seizures. So here's a quick summary of some of the literature for the use of perampanel in status epilepticus. So a study in 2015 by Rohracher and colleagues. This is a retrospective review that looked at 12 different patients with refractory status epilepticus that were treated with the perampanel. And they found that it ameliorated seizure activity in a few patients with refractory status epilepticus. And then a study in 2019, this was a retrospective review of 67 different patients with refractory status epilepticus, of whom 22 received perampanel. And they concluded that this may be an effective add-on therapy for RSE, even in patients who might have failed multiple AEDs previously. And then this study also found that it might be more effective for focal motor status epilepticus and convulsive SE than the non-convulsive status. And then finally, a cohort study that was conducted in 2021 by Lim and colleagues. They looked at 81 different patients with RSE or superrefractory who received perampanel for management. And they found that it was effective for the treatment of both RSE and SRC. And they also found that there was no cardiorespiratory or adverse events or laboratory abnormalities that were noted in this study. So kind of as a summary for status epilepticus, we do have a few different studies, but it's kind of limited data in terms of how we can apply this information moving forward. And then here's a summary of the literature for the use of perampanel in post-anoxic encephalopathy. So a study in 2015 was conducted. It's just actually a case report, sorry. And it looked at just one patient who had hypoxic superrefractory myoclonic status that was treated with perampanel. And this one patient had progressive clinical improvement with a CPC scale score of 1. And then finally, this is a pilot study conducted in 2018, looking at 8 post-anoxic patients with superrefractory non-convulsive status epilepticus that were treated with perampanel. And they found that a perampanel 6 to 12 milligram oral loading dose appeared to be an effective option in select patients that had the post-anoxic superrefractory NCSE and also had favorable prognostic indicators. So now we can kind of dive into the article that we're talking about today. So the purpose of this study was to evaluate the efficacy of perampanel as an add-on treatment of refractory status epilepticus, including PAE. So this was a single center retrospective cohort study that was conducted from January 1st, 2018 through December 31st, 2022. It included adult patients that were treated for refractory status epilepticus, including PAE, in whom perampanel was used. And then they excluded any patients with PAE in absence of N20 at the somatosensory evoked potentials. So for our patient population, so the study sample was analyzed as 2 separate subgroups, one for the patients with non-anoxic RSE and then one for patients with PAE. And the usual care for all patients in the PAE subgroup was initial treatment with propofol, phenobarbital, and levetiracetam. And the daily perampanel dosage was defined by the treating epileptologist. And also just to include that the dosing strategies as well were all kind of by the physician's discretion and not a standard protocol. So in terms of our patient stratification, so they stratify patients as perampanel responders, partial responders, and then non-responders. So for our responders, they showed substantial clinical and EEG improvement within 72 hours from the perampanel administration. And then they also had some classifications in terms of they didn't require any further medications with potential clinical or EEG impact being added during that interval. And then for partial responders, so these patients showed partial clinical and EEG improvement within 72 hours and or a late response at 72 to 168 hours. And additionally, I didn't include it on here, but patients who fit in the responder category, but started a non-anti-seizure med or an anesthetic drug that could potentially impact their EEG or their clinical stat or their clinical course in the 24 hours prior to the perampanel administration were also considered partial responders. And then for our non-responders, these patients showed minimal to no response to perampanel and or other anti-seizure meds that were added after the perampanel. So in terms of the outcome measures that they looked at with this study, so they looked at the number of anti-seizure meds that were administered before the perampanel, anti-seizure meds administered before these specific agents, and then the daily dosing of the perampanel, the time from the onset to initiation of either a benzodiazepine, first, second, third, or fourth line anti-seizure medication, perampanel administration, status epilepticus resolution, and this is specifically for the RSE subgroup. And then they also looked at time from onset to anesthesia, and then first, second, third, and anti-seizure med, perampanel administration, and then status myoclonus administration, specifically for the PAE subgroup. They also looked at the time from perimpanel administration to status epilepticus resolution, hospital length of stay, and then the MRS score at discharge. And so for our statistical analysis, so continuous variables, so these were compared within each subgroup according to the responder status using non-parametric tests. So they used a Wilcoxon test for 2 sample comparisons and the Crusoe-Wallace test for 3 sample comparisons. And then for any categorical variables, they use the chi-square test. So here, kind of diving into our key baseline characteristics for the patients in this study. So didn't include too much about the, in terms of our age and sex for these patients, but they were all pretty similar between the 2 groups. I did want to point out that all patients with non-anoxic refractory status epilepticus were treated in intermediate care units, namely neurology, neurosurgery, and general medicine. However, all patients with PAE were treated in the ICU. So that's just something to keep in mind. We had a little bit different treatment locations. However, majority of the similar baseline characteristics, were similar in terms of like the age and sex. So kind of diving into status epilepticus semiology, we can see that there were no significant differences in terms of semiology between any of these patients in both the non-anoxic RSC group and the PAE subgroup. Similarly, for the status epilepticus etiology, we didn't really have any statistically significant differences in terms of what our etiology was for both of the non-anoxic RSC group for responders, partial responders, and non-responders. And then also kind of to point out, we didn't see any statistically significant differences between the following baseline characteristics for patients with previous epilepsy, baseline MRS score, baseline GCS scores, and the STAS median. And so you can kind of see that there was pretty similar baseline between the 2 groups. And then similarly, just to kind of echo the previous, didn't really see any significant differences between any of the EEG features that were clinically relevant in terms of how we would interpret the results of this study. So kind of to dive into our key outcomes for the refractory status epilepticus group. So this was looking at the outcomes that were observed in the non-anoxic RSC subgroup, and it was stratified by response to treatment with the perampanel. So as you can see, didn't see any statistically significant difference in the number of anti-seizure meds that were administered before the perampanel, as well as the perampanel daily dosage in milligrams. And as you can see here, majority of patients received 8 milligrams daily. And so also just wanted to point out that I didn't mention earlier that patients in the study did not receive any loading doses, which is important to kind of consider when we talk about the discussion a little bit later. And so then we did see a difference in terms of the time from the onset to status epilepticus resolution in hours. And so we did see, which makes sense, a lower time to resolution in the responder group versus the partial responders. And then obviously didn't see any difference for the non-responders, and this was significant. And then additionally, we saw difference in the time from perampanel administration to resolution that was a lot lower in the responder group. We didn't see any significant differences in terms of hospital stay. And then we did see a slight difference in terms of the MRS score at discharge. However, it's not, again, clear if this is something that's clinically relevant, but just something to point out that we did see a statistically significant difference. And then here we have our key outcomes in the PAE subgroup, or the post-anoxic encephalopathy group. And so we only had 7 total patients that were in this group. And as you can see here, there wasn't really enough patients to actually determine any significance in these results. But just to point out that for patients who had a partial response, had a little bit of lower doses in terms of the daily dose of the perampanel versus the non-responders, which I would assume is probably just due to them trying increasing doses to see if it would help with resolution of the status epilepticus. With resolution of the PAE activity, sorry. And then also didn't see any statistically significant differences in terms of like hospital stay or MRS score at discharge between the 2 groups. So again, we just don't have a ton of information to kind of go off in terms of our PAE subgroup, which is, I think, a big limitation of this study. And they also looked at safety and tolerability. So there were no severe adverse events that were associated with the parenteral administration. They did have 5 patients in the RRC subgroup, as well as 1 patient in the post-anoxic encephalopathy group that died during the hospital stay for causes that were eventually deemed not related to the parenteral treatment. So just to kind of point out that there weren't any significant safety events. So in terms of the author's conclusion, so they concluded that the study provides empirical evidence supporting the potential efficacy and safety of parenteral as an add-on therapy in non-anoxic RSE, but the benefit of parenteral administration in patients with PAE was limited. So in terms of some strengths and limitations of this study, so they did attempt to evaluate the differences in outcomes between RSE and PAE groups, which I think is good because a lot of the previous studies didn't really differentiate or give any background in terms of the etiology and things like that. And also it evaluated patient-centered outcomes, which I think is really important, especially when we're looking at a study that we're trying to evaluate if this medication is going to be used in our institutions. And then some limitations. So this was a retrospective study design. It did have a relatively small sample size, so it's kind of hard to generalize these results to a wider population. Additionally, parenteral plasma concentrations were not routinely measured, so it's kind of difficult for us to know if we were achieving target levels. Additionally, continuous EEG was not available for all patients, which could be in part due to the differences in care areas in the hospital. And also, I think this is just important because it would be helpful to kind of know if we're actually making a difference in terms of our EEG activity. So in terms of our discussion, some additional discussion points I wanted to bring up. So the refractory status epilepticus cohort presented with relatively high MRI scores at baseline. And then the study did use lower drug doses compared to the other previously published studies. So again, like I'd mentioned earlier, we didn't use any loading doses, which is something that's important for this drug because it does have a relatively long half-life of a little over 100 hours. So without loading doses, it's kind of hard for us to know exactly like when patients would be reaching their steady state. And so this definitely could have affected our outcomes in this study. And I think that's a big limitation as well. Additionally, the modality of parenteral use and indications were decided on a case-by-case basis. And then finally, also just to point out that the medication, I guess, results in slower entry into the CNS than other agents that are commonly used for RSE, such as brivaracetam or galoxone. So kind of in conclusion, parenteral does seem to be a safe and effective option as an add-on therapy in patients who have non-anoxic refractory status epilepticus. But I do think that further studies are needed to determine its role, especially in PAE. We had a very limited number of patients in this study, so we only had 7 total. And there's just such limited data previously that has been published in terms of the use in PAE. So I think we definitely do need more studies to kind of determine what that role is going to be. So I think that in kind of a summary, patients that might be good candidates for using parenteral in refractory status epilepticus specifically would likely be patients that, one, can tolerate oral administration, also patients without significant renal or hepatic impairment, since these are some and things that they list in terms of things to watch out for when dosing, either dose reduction or just completely avoiding. And then also potentially patients, there's been some anecdotal evidence that have shown that patients who respond to ketamine may have response to the use of parenteral as well, which could be kind of in part due to the mechanism of inhibiting our glutamate activity, so that excitatory activity. However, I think this is something that probably needs to be studied more in the future. But I think those are some things that I would consider in terms of selecting a patient for using parenteral. But I think in general, it does seem to be a safe and effective option from the results of the study. We just need more information and larger studies to kind of give us more information on the best types of patients this can be used in. And that is all I had, but thank you. And I will take any questions that you have.
Great job, Madison. If you guys have any questions, feel free to speak up or put them in the chat. It looks like we have our first one in the chat. I don't know if you can see it, but it is. You mentioned ketamine. I missed if you would use this in place of ketamine or in addition to a ketamine infusion.
Yeah, so I'm not 100% sure. I know that our institution, we use Perampanel, but I'm not sure of if we use ketamine in addition. But I know that there were some additional studies that I came across when researching for this presentation that looked at the use of both Perampanel and ketamine together that showed some benefit for patients with refractory status epilepticus. So I would have to look and get back to you to kind of see, but I think that in general, I would recommend it if a patient previously responded to ketamine or showed some improvement or even partial response, just due to the similar mechanism is kind of my thought process. So probably together.
I had a question. And looking at the study, I don't know if I ended up catching this, but did the authors comment on their doses of propofol after perampanel was added? Did they have any comments on whether they up-titrated that propofol, added other anesthetic medications, so on and so forth?
Um, I don't remember off the top of my head specifically if they mentioned that. I know that they included specifically which anti-seizure meds were given before the perampanel, but I don't remember off the top of my head if there was any information about up titration, but I can check and get back to you.
All right. And your next questions, you have a couple more questions in the chat. First one is you mentioned perampanel plasma concentration. Is that something you would advocate for? And yes, if yes, what is your target level?
So I think I would probably advocate for the use of levels. Off the top of my head, I'm not 100% sure what our target levels. I'm sorry about that. I'll have to get back to you. But I do think that that's something that could help us to determine whether or not patients are even achieving adequate concentrations to see a benefit, especially in patients who might have partial response. I think it would be beneficial to kind of see if we just need to increase the dose or if it's something that's they're not going to see response regardless. But it's something that I would advocate for. And then I do see another question here. Let's see, from Chelsea. Let's see. So you currently have a patient with refractory focal status now on a ketamine infusion, and then you discussed the perampanel use, and she has an extensive psych history as well. So you're asking if I would consider perampanel use for this patient. I think from what I remember reading that this drug can potentially cause behavioral issues and agitation. So I think for patients with extensive psych history, it might not be the best option, and I would probably try to explore other options first. But I think it would kind of depend on the patient situation. But yeah, I do know that it can cause some behavioral issues, so it might be something to avoid in a patient with severe history.
I believe you have one more in the chat. Any concerns for drug-drug interactions? Going off the questions about drug levels, we use Oxcarb a lot at my institution.
So from what I remember reading, I can't remember any significant, like specific drug-drug interactions. So that might be something I'd have to look into and get back to you on. Because I'm not 100% sure if I remember like some key drugs that might interfere with the levels. So I can look and get back to you on that one. And then I think I got one more question also about loading doses. Yeah, so I think at our institution specifically, we usually give a 12 milligram loading dose and then continue patients on like the 6 milligrams daily thereafter. So I'd probably recommend anywhere from 6 to 12 milligrams for a loading dose, just based on the kind of the studies that I've seen as well as what we do at my institution.
All right. Well, I'm seeing no more questions. So great job, Madison. Again, if anybody has any further questions for Madison, you can put them in the chat. One question I like to pose to the group is, what is the typical perampanel loading dose you use at your institution? And then Michaela, I believe you can go ahead and share your screen. Let me know if you're running into any technical difficulties.
Thank you.
All right, I'm seeing your slides, so go ahead and take it away when you're ready.
Awesome. All right. As Jake introduced, my name is Michaela, and I'm from U of L Health, U of L Hospital. And today we're going to be talking about pharmacologic VTE prophylaxis in patients with non-traumatic subarachnoid hemorrhage requiring an external ventricular drain. All right, I am trying to advance my slides here, and I don't think that's working for me. All right, there we go. So our objectives for today, we're going to discuss the pathophysiology of non-traumatic subarachnoid hemorrhage, review the primary literature regarding VTE prophylaxis for patients with non-traumatic subarachnoid hemorrhage requiring EVD, and evaluate a study assessing VTE prophylaxis for patients with non-traumatic subarachnoid hemorrhage and the implications on clinical practice. So just to jump into a little bit of review before we jump into some of the primary literature. So a subarachnoid hemorrhage is the accumulation of blood between the arachnoid and pia mater. So you can see that there on the image to your right. These can be classified as two different things, so traumatic or non-traumatic. So traumatic, obviously, there's some kind of precipitating event that has preceded the bleed, or non-traumatic. So that's going to be the focus of our presentation today. So causes of non-traumatic subarachnoid hemorrhage, aneurysm is definitely the most prevalent, and that accumulates for about 85% of non-traumatic subarachnoid hemorrhage. Also, things like vascular malformations and intracranial arterial dissection can also certainly cause a subarachnoid hemorrhage. Cocaine use as well. And you'll see here in just a moment that that's also a risk factor for aneurysm development. Our stimulants can increase blood pressure, potentially precipitating a bleed, also and facilitation of aneurysm formation. And then also cerebral amyloid angiopathy. And the amyloid deposition results in fragile vessels, potentially also precipitating a bleed. So subarachnoid hemorrhages, there are around 30,000 new subarachnoid cases in the US every year. And these carry a pretty high mortality rate of around 25%. And of those that survive to hospital discharge, around 50% of those survivors are left with neurologic deficits. So these can be pretty extensive for patients and cause problems later on in life. So what are the symptoms of a subarachnoid hemorrhage? So thunderclap headache is going to be what we most commonly see patients present with. So they're going to come in saying, this is the worst headache I've ever had, rating it as a 10 of 10 on a pain scale. Also things like loss of consciousness and vomiting, neck pain, neck stiffness, and meningitis. And that is a clinical syndrome of headache, neck stiffness, photophobia, and that is really associated with the spread of blood throughout the CSF and down into the spinal cord. So aneurysmal subarachnoid hemorrhage, there are a variety of risk factors for aneurysm development. So things like hypertension, again, that really high pressure against the vessels can weaken them over time, leading to aneurysm development. Also things like smoking. So the carcinogens that are released when we smoke a cigarette can cause an inflammatory reaction with the vessels, weakening them over time, again, resulting in aneurysm development. Family history plays a large role here. Also, alcohol use, are some pathomimetic drugs like cocaine and methamphetamine with a similar mechanism previously discussed. And then also estrogen deficiency. So this is commonly seen in our postmenopausal patients as they have collagen wasting that can weaken the vessels, resulting in aneurysm development. As far as risk factors for aneurysm rupture, patients that are of older age show generally greater than 60. Posterior circulation location, so that in previous studies has been identified as a risk factor. This is a common location where aneurysms can develop, but also a very common location for aneurysms to rupture as well. Atherosclerosis also can be a risk factor here, hypertension, and intraarterial aneurysm size of greater than 5 millimeters. So how do we manage these patients when they present? So stabilization of the aneurysm is going to be our hallmark of therapy. So there are a variety of different avenues that we can take to be able to stabilize the aneurysm. Aneurysm clipping is a more invasive procedure that requires a craniotomy, and a clip is placed across the neck of the aneurysm, and that prevents inflow of blood into the dilated vessel. And so that really is a more invasive procedure, but that is an option that we can take. We also can have coiling, which is a less invasive procedure that involves floating of a peripheral catheter into the cerebral circulation, placing a coil within the aneurysm, and that induces clotting and blocks off the blood supply to the aneurysm. Something also that we can initiate, especially as pharmacists, is nimodipine. So early initiation of nimodipine has been beneficial in preventing delayed cerebral ischemia and vasospasm and improving functional outcomes in patients after aneurysmal subarachnoid hemorrhage. These patients also might require EVD placement for management of hydrocephalus. So this is not something that all patients will experience. Around 20 to 30% of aneurysmal subarachnoid hemorrhage patients experience hydrocephalus. So they may require EVD placement to be able to manage intracranial pressure. Lastly, blood pressure control is important for these patients because the higher the blood pressure, increasing our risk of rebleed. So that's definitely something that we would like to avoid. So the patients presenting with an aneurysmal subarachnoid hemorrhage are at risk for both VTE and also at risk for bleed. So these patients are typically going to have a prolonged hospital stay, going to be requiring potential surgical intervention, being immobile for a longer extended period of time, increasing their risk for venous thromboembolism formation. Previous studies have evaluated this patient population of non-traumatic subarachnoid hemorrhage patients and noted that around 4.4% of patients experience a venous thromboembolism during their hospitalization. Like I said, these patients are also at risk for bleed. So in patients that have an EVD placed, they're at risk for secondary hemorrhage. And tract hemorrhages can lead to worse functional and cognitive outcomes. And this is due to the placement of the EVD itself, generally going through the frontal lobe, which can cause some cognitive issues if this were to develop with patients. So moving on to what the guidelines recommend. So the Neurocritical Care Society guidelines recommend VTE prophylaxis with unfractionated heparin in all patients with aneurysmal subarachnoid hemorrhage. And this was a strong recommendation with high quality of evidence. They recommend starting prophylaxis with unfractionated heparin within 24 hours after securing the aneurysm. The American Heart Association, American Stroke Association guidelines recommend mechanical or pharmacologic VTE prophylaxis once the aneurysm has been secured. And this is also a class 1 recommendation, but they make no guidance regarding which pharmacologic agent is preferred. So jumping into some previous literature, the Neurocritical Care Society guidelines for the DVT prophylaxis for these patients, the recommendation for unfractionated heparin comes from this study from Lawrence and colleagues that was published in 1998, which was a prospective randomized unblinded trial of patients with intracranial neoplasm undergoing surgery. So patients were randomized to receive SEDs, enoxaparin, or a combination of the two. You can see the incidence of DVT here, but the focus of this, including this trial, was that the trial was terminated early due to higher incidence of intracranial hemorrhage in patients treated with enoxaparin. So that's really where the recommendation preferring unfractionated heparin comes from with the Neurocritical Care Society guidelines. Moving on into another study by Zachariah and colleagues in 2016. This was a retrospective cohort study of patients with subarachnoid hemorrhage with ventriculostomies. 53 patients received prophylactic anticoagulation. So you can see there, there was a variety of prophylactic anticoagulation used from unfractionated heparin all the way over to dalteparin. So with the results from the study, so four patients received prophylaxis to develop DVT. They reported the incidence of intracranial hemorrhage collectively for the entire population. So that was 59 patients, or around 25% of the total population of patients included in the study. And then as well as ICH with ventriculostomy placement. So 2 patients that were receiving prophylactic anticoagulation did develop an EVD tract hemorrhage. And so now jumping into our study that we're going to be evaluating today. So pharmacologic venous thromboembolism prophylaxis in patients with non-traumatic subarachnoid hemorrhage requiring an external ventricular drain. So this was a single center retrospective cohort study of patients admitted to the neurocritical care unit diagnosed with non-traumatic subarachnoid hemorrhage. This study was conducted patients were included from 2012 to 2017, and the patients were grouped based on prophylactic VTE prophylaxis that was used. So enoxaparin, unfractionated heparin, and then they also included a group of patients that did not receive prophylaxis at all. So this was the protocol that was used at the institution that conducted this study. So it was a weight-based protocol for enoxaparin dosing, and you can see there that patients with acute or chronic renal impairment or advanced age, so they used age greater than 70, received unfractionated heparin instead of enoxaparin. So they also initiated VTE prophylaxis in these patients within 24 to 72 hours after securing of the aneurysm, and they did anti-10A levels to correlate with the enoxaparin. They targeted an anti-10A level of 0.1 to 0.3 units per ml, and they dosed enoxaparin at 10 p.m. and collected anti-10A levels at 2 a.m. the next morning with AM labs, so giving a 4-hour period in between. And they also did this daily and made adjustments on enoxaparin dosing in 10 milligram increments. So our primary outcomes here were incidence of secondary hemorrhage. So that was mainly EVD tract hemorrhage that they were looking at, and then also the incidence of symptomatic VTE. As far as statistical analysis, proportions were analyzed using the Wilcoxon test, and the outcomes were initially assessed with a univariate logistic regression, but that was switched over to a multiple regression model using forward-backward selection was later used. These results were expressed as an odds ratio with 95% confidence intervals. So as far as enrollment, 1,351 patients were initially admitted to the neuro ICU with a subarachnoid hemorrhage. 483 of those patients were excluded because they did not have an EVD placed during their stay, leaving us with an enoxaparin group of 627 patients, an unfractionated heparin group of 114 patients, and no VTE prophylaxis in 127 patients. So going over some of the baseline characteristics, I'm just going to highlight a few here. So age in the low molecular weight heparin group was around 52 years old versus around 65 in the unfractionated heparin group. So this does correlate with the protocol of the patients that were in the unfractionated heparin group are going to be of older age, also going to have some sort of acute kidney injury or chronic kidney disease. These were primarily women. And they also used the World Federation of Neurological Surgeons scale to be able to verify subarachnoid hemorrhage severity. So the WFNS scale of 1 to 2, that correlates with a GCS of around 13 to 15. And then the WFNS score of 4 correlates to a GCS of anywhere between 7 and 12. So a lot of these patients were, had a GCS that was relatively normal, but they did include some patients that did have lower Glasgow Coma scores. They also identified some risk factors with these patients, so they're very common in what we would see in clinical practice, hypertension and smoking being the most common there in terms of comorbidities. So moving on into how these patients were treated, they were treated primarily with a coiling method of securing the aneurysm, and then also just to kind of point out inpatient mortality and 90-day survival here. So inpatient mortality occurred in 8.5% of patients on low molecular weight heparin versus 32.5% of patients in the unfractionated heparin group, again, correlating with the patients that were in this unfractionated heparin group were older and probably at higher risk for complications. Then 90-day survival, you can see there at 68.7% of patients in the low molecular weight heparin group versus 47.4% in the patients treated with unfractionated heparin. So jumping into our primary outcome, so VTE occurred in 7.5% of patients on low molecular weight heparin versus 4.4% of patients that received unfractionated heparin. That p-value there of 0.32, not indicating statistical significance, so really showing no difference in terms of prevalence of VTE between the two agents. As far as EVD tract hemorrhage, that occurred in 3.8% of patients on low molecular weight heparin versus 3.5% of patients that received unfractionated heparin. Again, showing no statistically significant difference between the two in terms of prevalence of EVD tract hemorrhage between the two agents. They also looked at some parameters that are risk factors for VTE development among these patients, and then also for ICH development. So they identified that the clip method of securing the aneurysm was associated with higher risk of VTE. But if we think about it, those patients are probably going to have that's a more invasive surgery. They're going to have more of a prolonged hospital length of stay. So that makes sense that we would potentially see higher rates of VTE in that patient population. They also identify the WFNS score of greater than 2 as a potential risk factor for a VTE development. Those patients are going to be sicker at baseline, also probably going to have a longer hospital length of stay. So that makes sense that we would see this here. As far as parameters for ICH development, they identified smoking and hypertension in terms of comorbidities of predicting potential ICH development. And if we think about it, that also those comorbidities kind of weakening the vessels over time, those patients are probably going to be at higher risk for bleed, and then also coil method as an increased risk for ICH development. So jumping into anti-10A level monitoring and kind of what they saw with this, this graph is a graph showing the trends of anti-10A levels over a several period of days. On the x-axis representing days and anti-10A levels on the y-axis. So we see that our anti-10A levels tend to stabilize here on around days 3 and 4 and stay pretty consistent. So that really goes along with the pharmacokinetics of what we know about enoxaparin, where we generally achieve steady state after days 3 and 4. So that shows also that we kind of stayed within that goal range of 0.1 to 0.3 as well. Looking at some more anti-10A monitoring and graphs that were provided by the study. On the x-axis, on the first one on your left there is evaluating the probability of VTE. So we're looking at the average anti-10A level on our x-axis and probability of VTE on the y-axis. So that red line is showing what they found. So generally we would think of the probability of VTE would increase the lower our anti-10A levels are, and that's what they did see in the study. So as our anti-10A levels increase, the probability of VTE decreases. On the next graph over on the right side, on the x-axis, looking at the average anti-10A level, and on the y-axis, looking at probability of bleed. So generally here, we would think of as our anti-10A levels increase, our probability of bleed increases, but you can see that red line stays pretty straight, and that's not necessarily what we observed here. So didn't really see a difference in terms of as the average anti-10A level increased, or did not observe an increased risk of intracranial hemorrhage development. So moving on into some other results, they also analyzed patients' home medications, and did that indicate development of VTE, or was that protective against VTE? They did note that antiplatelet use in patients with low molecular weight heparin was protective against the development of DVT. And then also want to direct your attention down to the bottom, looking at the anti-10A level monitoring. So you can see that our target goal range there was 0.1 to 0.3. And most patients that either developed VTE or did not develop VTE were within that, what they considered a therapeutic range. You can see that most patients, we had very low prevalence of subtherapeutic anti-10A levels, and then around 17% of patients that did not develop a VTE had an anti-10A level of greater than 0.3, so technically considered supratherapeutic based on their guidance. So moving on into the author's conclusion, so prophylactic enoxaparin and unfractionated heparin resulted in similar incidents of VTE and secondary intracranial hemorrhage. So jumping into strengths and weaknesses of this study. So I thought a strength of this study was that the patient population is very similar to what we see in clinical practice. So around 50 to 60 years old, these patients were primarily women. So we do see an increased risk in women as well. And then also along with the risk factors. So things like smoking, and then hypertension being probably the most common comorbidities that we might see in these patients. So they look very similar to what we would see if a patient with an aneurysmal subarachnoid hemorrhage walked into our hospital today. This is a needed study. So as you could tell from my literature review, there are no direct studies comparing enoxaparin versus heparin for this patient population. So I think this provides some knowledge on a literature gap that we previously did not have. And they also had a very standardized protocol for the initial enoxaparin dosing. So it left little room for confusion and little room for error there because it was very well mapped out in terms of what initial dosing the patient should receive. As far as weaknesses, this was a retrospective cohort study design. So we are relying on a lot of charting for a lot of the objectives and outcomes that we're trying to look at here. And because of piggybacking off of that, because of the retrospective nature of the study design, we were unable to control for VTE prophylaxis being held. So we know that these patients are likely going to be going for surgical procedures and other things that might result in their VTE prophylaxis being held. Could that have contributed to an increased risk of VTE? And then we also were unable to account for, was the timing of the anti-10A level being drawn correct? So if the prophylaxis was late, maybe was the dose or was the lab moved, or was it still drawn at the same time? So we really were unable to be able to see that. They also didn't have any standardized monitoring for VTE or tracked hemorrhage development. So what we saw in the prevalence was patients that were symptomatic. So if the patients were asymptomatic, this could have potentially underestimated the prevalence of VTE and also would track hemorrhage because we wouldn't have tested them or did any kind of imaging to be able to identify that. The unfractionated heparin group likely was at a higher risk for complication at baseline. So if you recall, those patients were older, generally older than 70. Our average age was around 65. So those patients could have been at a higher risk for complication in comparison to the enoxaparin group. So would the results have been the same maybe if the enoxaparin group was more similar, or if the heparin group was more similar to the enoxaparin group? And they also really didn't have a standardized process for enoxaparin dose adjustments based on anti-10A levels. They make the comment that they did 10 milligram adjustments in 10 milligram intervals, but really didn't have a standardized protocol for that. Jumping into my takeaway points. So as far as my conclusions, I think enoxaparin is an effective option for VTE prophylaxis in patients with aneurysmal subarachnoid hemorrhage with an EVD placement and did not pose an increased risk for intracranial hemorrhage. As far as clinical application, I think that the enoxaparin ease of administration is going to be preferred by patients and by nursing staff. So if we can save them, 3 injections a day versus 1 injection a day, I think that most patients are probably going to prefer that option. And especially since we know that it is not resulting in, or has been shown to not result in a higher prevalence of ICH or correlated in this study. As far as what are we going to do at our institution as a result of this? So I think that the findings could likely be extrapolated to facility-specific DVT prophylaxis protocols, whether that be weight-based or BMI-based protocols. As far as further studies needed, definitely prospective study would be needed to kind of confirm these findings. Also, I think it could be relatively easy to do a propensity match study to be able to match the patients that were in the enoxaparin group to something more similar that were also receiving unfractionated heparin. And at this point, I'll take any questions.
All right, it looks like you got your first question in the chat. Are you able to see the chat?
Yes, let me stop sharing my screen and I think I'll be able to see it.
Sure. If you need me to read it, I'll be happy to do that.
Yeah, if you wouldn't care to, that would be awesome.
All right, question is, do you use enoxaparin prophylaxis in patients with EVDs at your institution? If so, do you routinely monitor anti-10A levels in those patients? Last part of the question, also curious if you give VTE prophylaxis to patients with unsecured non-aneurysmal subarachnoid hemorrhage at your institution.
So we do utilize this in patients that do have EVD placement. We don't do routine monitoring of anti-10A levels among these patients. And then let me look at the last part of that question. And do we give VTE prophylaxis to patients with unsecured aneurysms at our institution? That I'm not as familiar with in terms of, just because I have not seen it, so I can definitely check into that and get back to you. Looks like the next question looks like if there was no difference in VTE rates between chemical VTE prophylaxis versus the non-chemical group, is it even worth recommending Lovenox and heparin? So the patients that were included in the no VTE prophylaxis group were either the patients that had very minimal bleeds, so they're probably not going to be in the hospital as long as these other patients, or the patients that had really significant bleeds to where it was very high risk to give them DVT prophylaxis. So I think that I still would recommend that because the patients that were included in that section were a little bit different than the patients that were included in the enoxaparin versus heparin group. So I definitely would still recommend DVT prophylaxis in these patients.
Does anybody have any more questions for Michaela? Right. Well, I am seeing and hearing none, so I guess we can conclude today's presentation. I want to thank both of the presenters. Oh, okay. A lot of good jobs. I was going to say maybe you got one last second one, but I want to thank both the presenters and I want to thank everybody for attending today's journal club.